Okay, so welcome everyone, and thanks very much for joining our journal club this evening. So I'm Sharif Awad, consultant bariatric surgeon from Derby. I'd like to welcome the co-chairs with me tonight. So we have Yitka Graham. She's associate professor and head of the McArdle Nursing and Research Institute in the University of Sunderland, I believe. So thank you, Yitka, for joining. We have Roxana Zakiri, council member also, and trainee rep. And we're delighted that the MDT from Chichester will be hosting the journal club tonight. And we have Chris Spring, who's going to be introducing the speakers. Just before I hand over to Chris, and again, in advance, thank you very much for supporting the journal club team Chichester. I'd just like to make an announcement of the next educational activity, which will be on Wednesday, the 22nd of September, 8 p.m. BST. And we have a free educational webinar to be delivered by Kelvin Higa, who's an absolute fantastic surgeon and speaker. And he'll be talking about the long-term surgical complications of Roux-en-Y gastric bypass and their management. So please do join us for that. Without further ado, I'll hand over to Chris. And again, the format will present two papers and then we'll take questions after each paper. Please post your questions via the Q&A button and let's give the team a good time with their Q&A. And then we're hoping to finish sharp at around 9:15. So over to you, Chris, and thank you very much for hosting tonight.
Thanks. Thank you, Sharif, for the introduction. Welcome, everybody. We're very pleased to present two papers this evening. The first one is going to be presented by Simon Federer. He's a core trainee in our unit, and he is conducting some excellent research into the effect of bariatric surgery on the biomechanics and biokinetics of the lower limb joints. So, Simon, feel free to tell us more.
Great. Yeah, so thank you very much. So the paper that I've chosen is one that's very similar to the research that I'm currently undertaking, and it's titled Excess Body Weight Loss is Associated with Non-Pathological Gait Patterns in Women 4 to 5 years after Bariatric Surgery. And that's not the most recent paper. It was published in 2014, but there hasn't been a significant amount of research on this topic since then. So why have I chosen it? As I said, similar to what we're doing, and currently I'm involved in a study that's investigating the effect of the rapid weight loss of bariatric surgery on the hip joint forces, walking gait, and quality of life. And on the right, you can see an example of the models that we're able to create through the motion capture. We're able to calculate forces, joint angles, and analyze everyone's gait. So this article was published in Obesity Surgery, has an impact factor of 4.129, and was published in February 2014. The authors were from Ohio, based out of Wright State University, Boonshot School of Medicine, and the study was funded by a grant from their Department of Community Health, and there are no conflicts of interest declared. So the paper had two main hypotheses. Firstly, that current gait in the post-surgery bariatric patient is normal for their current BMI. And their second hypothesis was that current gait patterns are related to longitudinal changes in weight, body composition, and functional status. So a little bit of background on firstly the gait cycle, which you can see on the right side of the screen. It can be split into a stance phase and a swing phase. The stance phase taking up approximately 60% of the gait cycle. And a few of the terms to describe parts of that. So you start with your heel strike and you end with your heel strike, and between that you have double support where both feet are on the ground and a single support where one leg is on the ground. And we know that in an obese population, they walk with a slower walking speed, they have a wider stride width, and they have a higher stance duration. So they spend more time stood on one foot. So this study was both a cohort and a comparative study, and their inclusion criteria were female participants over 20 years who had had Roux-en-Y gastric bypass surgery. And they had recruited patients from a previous study where they had investigated similar characteristics, but similar outcomes, but after a year. This time around, they were collecting data at 4 to 5 years after surgery, and they were able to recruit 9 patients. They then compared that study population to a reference sample from a longitudinal study, again, of participants out of Ohio that were age and matched to the bariatric sample. Exclusion criteria were if patients had had joint replacements before, if they had chronic gait disorders, and if they'd had a previous or recent injury to their lower limb, pelvis, or spine. Now, it's important to mention that osteoarthritis was not an exclusion criteria because we know that OA and obesity are closely linked. So the bariatric cohort, they were assessed preoperatively and 4 to 5 years postoperatively, and the Fells reference sample was measured on one occasion. The outcome measures that they looked at were body composition and anthropometric measurements. They measured a timed get up and go test where the participant is sat on a chair, is asked to stand, walk 3 meters and return and sit down on the chair. And they have performed quantitative gait analysis in a biomechanics lab with 3D motion capture, and they've also conducted a short musculoskeletal functional assessment questionnaire, which you get a bother and a functional score, with a higher score indicating a higher issues with pain from your musculoskeletal system. And because the bariatric sample was not normally distributed, they used non-parametric methods for their statistical analysis. So first, thinking about the bariatric sample, not unsurprisingly, after 5 years, they'd lost a significant amount of their body weight and their excess body weight, and there was significant differences in their timed get up and go test, and both the bother index and the functional index. The authors also looked at whether there was any association with increasing loss of excess body weight and time spent in the double support phase and the single support time of the gait cycle. And they found that, as on the left graph, as that excess body weight loss increased, the participants spent less time in that initial double support time, and as the excess body weight again increased, that single support time proportion increased. They then, to try and answer their second hypothesis, tried to see if there was an association between those changes in excess body weight, abdominal circumference, time get up and go with those gait parameters. And the only 2 parameters that they found an association or a significant difference with were the initial double support time and the single support time. They did not see a significant difference between the bother index or the functional index, or the time get up and go. They looked at whether the gait, the velocity was associated with the get up and go time, and which would make sense. And as that get up and go time decreases as you'd expect the forward velocity to increase. And aside from one outlier, they found that there was a positive correlation. Comparing, and then the second side of the sort of half of the paper, they compared the bariatric sample to this reference cohort, and table 3 describes the features of the two to show that they were pretty comparable. The only significantly different parameter was the lower limb length, but that can be adjusted for in for the gait analysis. So comparing, so these graphs are looking at both the Fells cohort and the bariatric cohort, and the bariatric samples are the dark shaded circles. And these are regression lines with 95% confidence intervals in the dotted lines. And on the whole, the participants after 5 years, their gait was very similar to the reference cohort. The only one that there was not is the bottom right, which they found the step length was not in the reference cohort. There was no association between excess body weight and step length. So the authors suggested that the improvements in gait are maintained 4 to 5 years after surgery. They found that the participants had a longer and narrower steps were taken and walk at a higher cadence. But they did comment that 7 of the 9 participants walked at a lower cadence and more slowly than expected for their current excess body weight. And they found that a greater weight loss was correlated with less time in double support and more time in single support. And they found that there were improvements in the SMFA index and the time get up and go times. And they commented that the preoperative time was that of an 80 to a 99-year-old. So to conclude, they found a significant improvement in their physical function with excess weight loss after 5 years, and they felt that the gait signatures were characteristic of current weight rather than pre-surgical weight. So my thoughts on the paper were that it's one of the longest follow-ups of any study of this type, and they used appropriate methods of measurements and outcomes. However, concern is that there may have been a bit of selection bias based on the fact that they were recruiting patients from a previous study, and they were able to only ask, or only able to get 9 people to participate in this study. The difficulty with a lot of these studies is that only female participants are involved. I feel that they could have perhaps done a bit more with the quantitative gait analysis side of things. They didn't look at the joint forces, so the kinetics, or the movement of the joints, so the kinematics. And they didn't measure every single variable at each visit. They also mentioned that in the bariatric sample, 1/3 of the patients had osteoarthritis, whereas the longitudinal, the reference sample, only had 9% of the participants had osteoarthritis. With regards to their results, they're in keeping with a couple of previous studies which found similar outcomes. And they mentioned that they didn't have any interim data with regards to how the gait is changing. So they'd measured them preoperatively and then at 4 to 5 years, and it would be useful to know how things are changing 6 months, 12 months post-operatively. I felt that they answered their first hypothesis clearly. However, their second hypothesis in table 2 were perhaps a little bit more, they could have been a little bit more concrete with their answer of that. So to summarize, I feel that this paper highlights the plasticity of gait through weight loss, and that it's useful to gain a greater understanding of this weight loss, the change in gait in patients with obesity, and this is useful for understanding other conditions, for example, the pathogenesis of osteoarthritis, and better understanding of who is going to hold on to pathological gait patterns would be useful to guide and direct physiotherapy. And as I said before, a greater understanding of how the forces are changing through the joints would be useful. And there are some references.
Thank you very much, Simon. That was a fantastic presentation. Actually, really interesting to have something more kind of cross-disciplinary as well presented. I believe Yitka's got a question to lead. Would you like to go here first, Yitka?
Yes, I will. I'm just going to read it out. It was just it was posted sort of before the chat. Simon, one of the questions that was asked, it's sort of a question, more of a statement. It's not clear the correlation of the changing of the gait associated with obesity with any pathology. Could you sort of explain, or have you got any thoughts on that?
I'm not sorry. Could you repeat the question? I'm not sure.
Yeah. So one of the participants has said it's not clear to him the correlation of the changing of the gait associated with obesity with any pathology. Have you got any thoughts on that?
So, I mean, I think, yeah, I'd agree. It's hard to know what other pathologies are occurring, and certainly we know that, and as in this example, a third of the patients had known osteoarthritis, and so that would have an impact on their gait. That's not something that they've really commented on at all in their discussion, and they've not done any form of sort of imaging of the lower limbs to sort of explain or suggest that there's been any progression in other pathologies. So I agree, yeah, that there could be other factors at play here.
Simon, is there a way to train people with obesity to walk with a safer gait in a way that's kind of less damaging to their joints, or is it something that's purely mechanical based on their anatomy?
I'd imagine that there are methods to do that. I suppose thinking about this from an orthopedic side of things, and patients who undergo hip joint replacement surgery in particular, immediately post-operatively, they're walking with a very similar gait to how they were walking pre-operatively. And that's not particularly helpful, and they need to be retrained to walk in more of a straight line rather than with a waddle. And that is something that patients can be guided and trained to walk with perhaps a better gait.
Simon, I've got a couple of questions for you. One, the clinical relevance of this sort of data and this sort of research, and I'll come back to sort of what sort of work you're doing and how you're contributing after your research. So one is the clinical relevance of this paper and the study. The second question, I guess, is not many bariatric services have physiotherapists as part of the MDT. We're very lucky in Derby that we do have a really keen, active physiotherapist who really, really helps out in our enhanced recovery. The hope was that we'd implement some sort of exercise sessions for patients to commence 6 weeks, 8 weeks post-op, and they would be physiotherapy led while they're having their dietetic review in the clinic. But COVID pretty much scuppered all of that. So any comments on sort of the role of a physiotherapist within the bariatric MDT and its importance, and also the clinical relevance of this work, please?
Yeah, of course. So I think the clinical relevance is, I suppose, related to other conditions, and in particular, broadly speaking, sort of musculoskeletal pain and then pathology. And at the moment, we don't have a fantastic understanding of exactly how things change rapidly with that weight loss. And then thinking a step further is we don't fully understand exactly how the pathogenesis of osteoarthritis. We know that there is an association with obesity, excess weight, and the progression of OA, but we don't quite know exactly what's the sort of the causal pathway is. So a greater understanding of exactly how this weight loss is changing someone's gait and the forces and moments going through people's joints is changing will give us, well, could potentially give us a clearer understanding of how that pathological loading is changing. And sorry, what was and then the second question was with regards to sort of physiotherapy.
The role of physiotherapy input into the bariatric MDT, and is it of value? Should we be encouraging more physiotherapists to be part of our services?
I think, yeah, I think potentially yes, and I think that's something that's an avenue that could be explored with future research that's being undertaken in our lab at the moment. And I think having that sort of better understanding of how patients are doing without any intervention, and perhaps if they could then be trained or guided to walk in a more efficient and less pathological manner would be best.
Should I just make one comment just to summarise, if you don't mind? Well done, Simon. Just for people who are listening in, Simon is actually a core trainee, and he's an orthopaedic surgeon. What we're trying to do at Chichester is bring in people from other disciplines to populate and to pollinate some cross-disciplinary research. So we also have a gynecologist, a core trainee who's looking at PCOS and is doing a lot of ultrasound of the ovaries before and after surgery. We have another guy who's looking at gut permeability, which is interesting for the ICU doctors. So one of the main aims of this is to get Simon, when he becomes an orthopedic consultant, out at the orthopedic meetings talking about bariatric surgery. So we are really trying to spread the message outside of our confines and spread it into a wider community. So Simon, as you can see, is bright, he's articulate, and he's on a good number here. So this is what we're trying to do. So well done, Simon.
Superb, Chris, and well done, Simon, from me too. Fantastic presentation. In the interest of time, Chris, we've had another question come in the Q&A, but I think we should move on to the next paper, if you can introduce that one. And if you get a chance to answer that question as you've done, that would be lovely.
Very good. So thank you, Sharif. So the next paper is from Saurav, who's our research fellow. It's a topic that we're very interested in Chichester, and it's how, well, we're all interested in it, but how do we manage acid reflux in the sleeve gastrectomy population? And our interest was first really piqued on this topic by listening to David Knocker, who I'm very impressed with personally. But Saurav is going to talk to us about the Rossetti fundoplication and whether we should consider applying it to those patients who have sleeve gastrectomy.
Right. I'll just share my presentation. Right. So, hello. I'm Saurav, and I'm the current bariatric fellow at Chichester. And thank you for this opportunity to present this talk, which I think is quite interesting. And it's a technique that's described combining fundoplication with sleeve gastrectomy, the Rossetti procedure, in patients with established reflux. And this is done by a group from Milan. And this was published in SWORD earlier this year. And we all know reflux is a problem in patients who've had a sleeve. The two recent RCTs have actually shown that a sleeve is almost as good as a bypass in terms of outcomes in 5 years. But there are more complications with a bypass. However, there's a more correlation with patients having reflux-related problems afterwards with the sleeve. And we can see all over the world, sleeves becoming more and more popular. You've seen just itself in the last couple of years, the number of sleeves we're doing have just gone up, and they're at par, if not more than bypass, and that's all across the board. But we've also seen recently this year that meta-analysis has shown that Barrett's risk increases after sleeves over 10%, and if it's over 10%, that merits, according to some guidelines, merits regular screening. So, but this is after a sleeve. What about the patients who have reflux, come to us, and say they do not want a bypass or they're not appropriate for a bypass. How do we treat them? And usually we've always said that the gold standard is give them the obese patients, give them a bypass, because that will treat the sleeve. But that's not entirely correct, because if you look at this study from a couple of years ago, where almost 2,500 patients were evaluated who had reflux and had a bypass, about half of them within 2 years had recurrence from the symptoms. So how do we manage patients with reflux with a sleeve? So fundoplication has been tried as a technique in addition to a sleeve to see if it works. And like Mr. Pring just mentioned, the Nissan sleeve, as described by David Knocker recently, was a very good example of a procedure where you did a 360-degree fundoplication with the fundus along with the sleeve, and it showed pretty good results. And there were a few anecdotal similar procedures in the past. And there have been other innovative ideas like using a Lynx procedure with the sleeve. But this group from Italy, they thought that why not try the Rossetti procedure, because in their unit and in Italy, I believe the Nissan Rossetti fundoplication is the anti-reflux procedure that they use in Italy. And I think they've got really good results, and more than 90% reflux improves in 5 years. So their aim was to see whether they could combine the Rossetti anti-reflux procedure with a sleeve in the bariatric patient. Now, so this was a prospective study, from a high volume center approved by ethics, and the inclusion criteria was patients with morbid obesity based on guidelines exactly like our NICE guidelines, but with established reflux. And by that, they meant the patients met the criteria, the Montreal criteria definition, but the Montreal definition is a bit subjective. The definition is patients who've got symptoms of heartburn or reflux, which are troublesome, and the troublesome is not really well defined. So they've incorporated in the inclusion criteria patients who have established esophagitis on endoscopy. So all patients had no GERD, which showed esophagitis. None of these patients or a pH manometry wasn't part of their protocol, and their rationale was that the values of these tests are not standardized for these patients. So they calculated a sample size, figured out that they required about 45 patients to show that there was any improvement of reflux. And that's based on the fact that after a normal anti-reflux procedure, we expect a 3% recurrence rate at 1 year. So the steps of surgery. So what they did is they started off with mobilizing the greater curve as we would with a normal sleeve. Then they dissected out the hiatus, but they were quite keen to avoid excessive dissection. They wouldn't do too much of a gastric dissection, and did minimal dissection of the crura and hypogastric ligament, just enough to allow the anterior wall of the stomach to slide through without tension. And their rationale was that they did not want to disturb the barriers that are in place, anatomical barriers in place to prevent reflux, and therefore mitigate the chances of having an intrathoracic migration at some point. So they created about 1.52 centimeter floppy valve around the front of the esophagus without putting any stitches on the esophagus. And then after that, they placed a 38 French bougie, and then resected the stomach, including most of the fundus. And I'll just show a diagram here which explains the Rossetti procedure. So in Nissan's is when you get a 360 degree and you take the end of the fundus and wrap it around. Whereas here in the Rossetti procedure, they take the anterior wall and they slide it behind the esophagus. So this bit, I don't know if you can see it on your screens, but it slides to the right of the esophagus, and further back on the anterior wall that constitutes the left pillar of the valve. So they're stitched together without incorporating the esophagus. And then once the bougie is in place, you can safely resect all this as you see, they resect most of the fundus with this procedure, which is probably the difference with the Knocker's procedure, or the Nissen sleeve as described by Knocker. So their follow-up included upper GI series in day 2, which is probably because they wanted to have a look at the anatomy, make sure there isn't a leak. And then they followed them up on regular periods until 12 months, including and did quality of life assessments, and they wanted to do an endoscopy in all patients at 12 months. So looking at the results, so they had 58 patients, predominantly women, BMI about 42, and all patients had reflux symptoms and had some form of esophagitis, and they were all on PPIs. So looking at the reflux outcomes. Now, if they had a hiatus hernia, if it was over 2 centimeters, an obvious hiatus hernia, they would fix it. But if it's a small hiatus hernia or a tiny bit of weakness, they would not do a full hiatal dissection. And as you can see, about 50%, more than 50% did not have a cruroplasty of any sorts. All patients, they stopped PPIs at 2 months. And at 1 year, based on the Montreal definition, no one had any symptoms of reflux. And they managed in the end to do an OGD in about 35 patients, that's 60% of the population for various reasons at 12 months. So they couldn't do the entire population. And of that population, only 2 patients had some form of mild esophagitis, and none of them were symptomatic. So 33 out of the 35, the esophagitis had resolved. And overall outcomes, weight-related outcomes, were exactly what you'd expect in patients who've had sleeves at 1 year. The operation did not take very long. It was about 52 minutes. BMI dropped to about 28. Hypertension, diabetes resolution, remission, as you can see, was quite good. And the quality of life score significantly improved at 12 months in all these parameters. So the so as a procedure, considering the outcome of a sleeve, I don't think that was compromised by having this, having the fund application. Now looking at the complication, now there were 2 patients early on in the group who did have a perforation. Now this perforation is found to be at the, at a part of the bit of the fundus that's brought around as a wrap. And they were all picked up on the upper GI series. So they went back to theatre day 2. They undid the wrap and just resected that bit of the fundus. And their theory is that that bit of the fundus was a bit compromised because of the traction or dissection, or probably even related to injury from energy sources they used. But this is not related to the leak, to the staple line at all. 2 patients had hematomas, neither of which needed an operation. 1 needed transfusion. 1 patient at 5 months had a disruption of the fundoplication. They went back and redid the wrap. There's no details of exactly what happened and why that disruption happened. And none of the patients needed any dilatations or had any other complications that you'd expect with an anti-reflux procedure like dysphagia or gas bloat, etc. None of that was mentioned. So overall, they concluded that this procedure is safe and effective in the short term. They called it a tie sleeve. However, because of the couple of perforations, they really think that a bit of training is needed, and there is a bit of a learning curve involved with this procedure before you could use it as part of regular services. So, looking at the paper, it's a well-designed paper, I felt, but one of my questions is what happens to the patient who comes to us with symptoms suggestive of reflux, significant symptoms, but when we do an endoscopy, we don't find any esophagitis. Do we proceed to a sleeve with this kind of fundoplication or not? I'm not sure that this paper quite answers that question. Would it have been worthwhile doing using the GERD questionnaire, which is a standardized questionnaire to look at symptoms, and maybe using this questionnaire, you might have actually found some patients have recurrent symptoms at the moment. Although they didn't mention complications of the anti-reflux procedure, which are known like dysphagia, gastrolysis, etc. I think it would be nice to know a bit more, and I think they need a bit a longer follow-up to know about that. And the question about safety, about those perforations, that's obviously there, but that's probably a technical issue, and one just needs to be very careful with dissection, especially around the top of the fundus. Normally that's resected, and here that part of it is left behind. I think looking forward, I think we have to start thinking of comparative studies and figuring out which is the best procedure in this scenario. Is it a Nissen sleeve? Is it a Rossetti? Or is it chloroplasty enough? And I think we have to compare it to a bypass. And with in these patients with established reflux, to see if a sleeve with a fundoplication procedure is good enough. I don't think it'll be ethically possible to compare it with controls at this stage. And we have to find out what the long-term impact of these procedures are. So we'll have to wait for the long-term data from studies like this, effect on parrots. How do we follow them up? If you look at the ifs or statements on reflux, OGDs, following sleeve and bariatric procedures, they fell short of actually recommending it, but they suggested that we probably need to do endoscopies every 3 years after the sleeve, because that's when you would get Barrett's. But if you've had a fundoplication, do you need that? So yes, I think it was quite interesting paper, brought up lots of questions, and just shows us which way we are going in terms of dealing with patients with reflux and being able to give them a sleeve. Thank you.
Well done, Saurav, and thank you very much, team, for a really, really topical and I think quite an important paper, actually. I think the topic does need to be covered and looked at, and lots of groups trying to think how we best manage the patients with reflux who do want a sleeve, because there's a lot of patients out there, they don't want the bypass and they don't want the potential long-term surgical complications of the bypass, and they will do anything to get a sleeve. And I think anything that adds to that data is useful. Just question for you, Saurav. Would you do this procedure? Would you, when you get your consultant job, would you actually do it?
The honest answer is I'm not trained to do the procedure as yet. I'd like to see this, train in it, watch a few procedures. I'd like to know a bit more about the long-term effects. And like I said, I really would like to see a comparative study comparing bypass and sleeve with an anti-reflux procedure in patients with established GERD. And that would help me decide. But yes, I'd be interested to learn and see more about these kind of procedures.
Okay, Chris, quick question for you before I fire a couple of questions from the audience that have come through. In terms of you as a group in Streamline, what's your personal experience on outcomes of patients with reflux who you've offered sleeves to? Do you offer them sleeves, or is it just direct?
Yeah, yes. So, I've had a slight paradigm shift in the last 5 years. And we like to offer sleeves when we can, but we're mindful of the reflux argument, and it's unresolved. You've got to remember that a bypass doesn't necessarily resolve reflux, and also bypass invites a lot of potential complications. A very good operation, but we have to try and balance these whole things out. The other thing we've got to play into this is, which is slightly separate but almost related, is what sort of surveillance should we be doing on our post-sleeve patients? Because no one gets routine endoscopy, and I think we've got to start heading towards that. But really, we've all experienced difficult patients with reflux after a sleeve gastrectomy, and it's a very, very hard situation. So we need to work out, is can a fundoplication resolve that?
Yeah. Okay, we'll go to Roxana and Yitka, and they will pass on some audience questions to you.
Thank you very much. And I guess following on from that comment you just made about surveillance, is that, Saurav, do you think the symptom relief or the esophagitis relief that the patients had in this study was due to the procedure or due to the weight loss, or both? And how can we delineate between the two? Is it possible?
Yeah, that's a really interesting question. I don't think we can ever delineate that. I mean, like Ms. Spring was mentioning, we offer sleeves to our patients if they have reflux, even if they have some reflux symptoms, unless they've got an obvious large hiatus hernia. And sometimes if you ask them closely if they've lost weight during their journey towards us, has the reflux symptoms improved? And sometimes say, yes, when I've lost 5 kilograms of weight, my reflux improved. And you kind of think that, well, maybe if you have a sleeve, you lose weight, if that's contributing to your reflux, it might get better. Again, if you look at the study, all patients had PPIs for 8 weeks following surgery. So was it the PPIs that improved everything? Difficult. So unless you have a comparative group, you cannot answer that question. And yeah, that's my feeling.
That's very true. And then just on a technical note, we have a question from the audience. Was it mentioned in the study what type of staplers and the size that they used towards the top of the sleeve, towards around where they were making a wrap?
No, I think they used Medtronic staplers, but I don't. They didn't they didn't mention the thickness of the staplers used around the fundus. They didn't say that they'd use anything differently, as you would with a normal sleeve, suggesting they'd use the normal size thickness, but that's just speculation. It's not mentioned in the paper.
Yeah. Do you think it would need anything more different?
It shouldn't. I think it should. I don't think it should. Not unless you're coming across 2 layers of stomach, which you shouldn't be at that stage. If you look at the diagrams, they're not coming across 2 layers of stomach.
Okay. Thank you. Jitka?
Yeah, there's a question here. First of all, it said to thank you for the presentation, but the comment is, it's a shame they use such a nebulous way to define reflux. Did the authors say how they managed these patients prior to adopting the procedure?
No. The patients came to them on PPIs. They did an endoscopy, showed that they still had esophagitis, and then they went ahead for surgery. They didn't do anything else before surgery.
Right, okay, that's great, thank you.
And a comment from, I think Gwen Davies might be a bariatric nurse specialist, but they're saying that obviously if you're having bariatric nurses on the ward they're not used to seeing fundoplication patients and being able to pick up what sort of symptoms would suggest a problem going on, that this could potentially cause a problem for the patient. So additional training and exposure of the nursing staff to these new procedures, I guess, would be of importance. There was a question from Waleed, which I'm not sure if you answered. So Waleed Al-Kayat from Derby, and he suggested that symptom relief or esophagitis relief would be weight loss related, as opposed to due to adding on the Rossetti or the Nissen sleeve. What do you think?
It's difficult, like I said earlier. I think it's very difficult to tease that apart unless you have a comparative group of similar patients. I think that's what's needed next.
Okay, final one from me to Chris. So Chris, when you're doing sleeve mild reflux, which is food related, patient is on off PPI, it's nothing huge and you're happy to offer them a sleeve and the patient's happy. If you do see a 2 centimeter crural defect, would you routinely repair that in your practice?
Yeah, we're very aggressive at the hiatal dissection. I mean, often you find a big lipoma at the back of the posterior fat pad and it gets so yeah, we're very aggressive at following the phrenoesophageal ligament all the way around and often doing the right crus as well. So if you look at David Knocker, he does it for everybody. We're only going to answer the question by an RCT, and I think it's something that affects all of us, and it's something we should try and resolve in a better way, because sleeve is going to stay, but we need to make the symptom relief better functionally for patients.
100%, and I think a UK multi-centre RCT looking at the various options that we have at surgery would be really invaluable in this cohort. So we've come to the end. So can I just thank the entire team at Chichester for your fantastic presentations, and Simon, please keep up the great work you're doing and do well within the orthopedic circles, and it's great to have you involved. I think it's fantastic insight from Chris and team at Chichester to bring you in and involve all the other specialties in the way that you're doing, Chris. Jitka, thank you very much for joining. Roxana, thank you for co-hosting. I forgot to thank Ethicon, who have sponsored the meeting tonight, and just a final reminder for our next educational webinar on 22nd of September. And thanks very much for the audience for your questions. Okay, good night, everybody.
Good night.
Good night.